Thank you so much. So, we were talking last night about the hope is that the solution to everything is Italian food. But, it's one of those things. Or again, knowing me, hopefully Italian suits. But there you go. So one of the things I would say is that Oman met me here at the airport and met me at the hotel, and I didn't realize that this was actually going to be broadcast online, which immediately made me regret not bringing my big cowboy hat and a belt buckle. So I apologize, and we'll just see if the accent comes out while I talk. But it's an honor and a pleasure to be here today. It's, again, just a fantastic time to be taking care of patients with melanoma, which, again, it was the exact opposite experience when this seminar series began. We talked about this last night, that 10 years ago, they struggled to figure out what to talk about. And we've come so far. It's actually now one of those things of trying to narrow down, well, what should we talk about today? And it's a really great sort of environment to be in. One of the things that I like to just sort of start talking about, and this again is something that I think will be discussed after the break as well. So as Omen mentioned, I'm a physician scientist. I do see patients, I do run trials, but I also work in the laboratory. And in particular, although I learned how to work in the laboratory, learned how to work with mice, how to work with cell lines, my desire was always to do what we call translational research. And that means doing research that not only applies to making my mice live longer, but how do I make patients live longer? And what's been so transformative in melanoma is translational research, which is a partnership between physicians, investigators, and patients. Because all of the research I'm going to tell you about today couldn't have been done without the generosity of patients, not only participating in clinical trials, but even getting standard of care agents agreeing to let us draw an extra sample of blood, or letting us do tumor biopsies, or as was mentioned, which I never imagined we would be doing, sending us vials of poop. So we've come a long way, but again, it's a real honor and a pleasure to be able to participate in a patient symposium and hopefully to talk to you about the impact that patients have been having, not only on melanoma, but on other diseases as well. Now, this next slide shows my disclosures. I do work with many companies, and actually, this is another partner we have in this disease. Actually, much of the research has been enabled by getting access to those drugs that patients are taking now, drugs that we hope will be successful in the future, but even seeing clinical data from clinical trials where the companies came out spontaneously to say, hey, maybe you should take a look at this data that we have. And so again, it's one of the other things we talked about over dinner is just how collaborative a community we have in melanoma, and how I think that's been really critical to the advances that we've made. So melanoma is really the poster child of translational research in the field of oncology, I think. And again, translational research starts from doing research to provide new insights into a disease and then figuring out how to translate that into clinical impact. And so the excitement that we've had in the last few years with new treatments, actually, if you look back, started out with laboratory research. And then what's been so fascinating in melanoma is that we had these parallel breakthroughs in understanding much more about the drivers and heterogeneity of this disease and the key regulators of the immune response against melanoma. And so on the cancer biology side or tumor biology side, this is a slide that was published a few years ago that shows when we do whole exome sequencing all of the DNA that's present in a tumor from start to finish, looking at over 30,000 genes, the distinctive feature of melanoma compared to all other tumors is that on average, melanomas have more mutations than any other cancer. And actually, the very first melanoma that was sequenced this way, we actually found 30,000 changes in the DNA of the tumor cell than the normal cell from that patient. Our problem isn't finding a mutation, it's figuring out which mutations are important. And for patients who have cutaneous melanoma, in approximately 70 to 80% of them, we can actually find the mutation that makes the tumor grow. And what we've been able to do is convert that knowledge into inhibitors that block those key mutations to generate clinical benefit. And while in most fields you would be happy just to accomplish that, what was remarkable in parallel was the work. And again, you heard about this in the last talk, about new breakthroughs in understanding what tumor cells do to dampen the immune response against cancer, which presented opportunities to pull the brakes off of the immune system to induce a robust anti-tumor immune response. So again, research like this is something that we've done for a long time. What's been so thrilling in melanoma is not just to make insights in the lab, but to convert those insights into new treatments. And so when I started taking care of patients with melanoma in 2007, the genuine standard of care for a patient with melanoma is to go on to a clinical trial because the treatments we had actually never been shown to make people live longer. And some could argue that, again, going on to a clinical trial should probably still be the standard of care because as much progress as we've made, we want to do better. But what is the new world is that between 2011 and 2018, we had 11 new treatments approved for patients with stage 4 melanoma, all of which improve overall survival. And as you also heard, many of those new treatments that we've been using in the most advanced stages of disease have now shown benefit in patients with regional melanoma or stage 3 disease. And we actually have clinical trials going on to ask in those patients with clinically localized disease that Dr. Ferries talked about at the beginning to ask, should we be using them in those patients as well? What's very interesting is that for many decades when we came out with new treatments, they were chemotherapy, which is literally poison, where we're just trying to poison the cancer cell faster than we poison the person. What's been so remarkable here is that the 11 new agents don't include a single chemotherapy drug. They're evenly divided between those targeted therapies, which are all based on understanding what are the mutations that cause and drive melanoma, and immune therapies, all driven by research that helped us to understand how do tumors evade the immune response. And with that, we've seen tremendous progress. Again, when I started taking care of patients, for patients with stage 4 melanoma, the average survival was about 6 months. And it's probably now 2 years and maybe even longer. We still don't know because our data keeps needing to be updated. And so that's a tremendous amount of progress. But as we talked about last night, and you'll hear from Sam Guild a little bit later, we recognize it's not enough. And so what I would argue is having sort of done this with targeted therapy and immune therapy, what are the other opportunities to build upon the success and build upon this momentum to further improve outcomes with the ultimate goal of eliminating deaths from melanoma? And so with that as a background, I'd like to talk to you today about what we think is a very interesting and important player in this disease, and that's metabolism. So shown to the right is a very complicated picture. And for those of us, again, who went through medical school and graduate school, this is the picture that gave us nightmares in our biochemistry classes. So these are the metabolic pathways that are present in cells. This basically is laying out how do cells use nutrients to actually generate the building blocks that cells need to survive, to thrive, and to grow? And one of the things we've known for a long time is because cancer cells actually grow faster than average cells, what many cancer cells do is they actually change the way they use these metabolic pathways to give them the ability to grow more than they should. Again, we've thought about metabolism historically as something that's impacted by what we eat, by how much we exercise. What's been new is understanding in the last few years that those same mutations that drive cancer cells to grow can also change the metabolic pathways that we have active in the cancer cells. We also have new information that changes in metabolism can be very important not only in immune cells, but also in how tumor cells try to evade the immune system. And what in the end is actually really important about this is that many of those little circles and little pictures are things that we can actually target with medicines. And so if we can understand what is the role of metabolism in melanoma and other cancers, maybe this will provide us some new opportunities to, again, make further improvements in this disease. And so with that, I'd like to talk to you just with a couple of vignettes about some of the work that we've been doing at MD Anderson, some of which has happened in my lab, but some of which, again, I've just been thrilled to be a part of and watch happen. And in particular, to talk first about the role of diet in the microbiome. This is something, again, is of great interest in many fields, but is increasingly of interest in cancer. I would then like to talk about something that's a particular passion of mine, which is understanding the role of metabolism in the development and therapeutic resistance of brain metastasis, which is historically and remains our worst case scenario when we're treating patients with melanoma. This is the thing we're afraid of. This is the thing patients are afraid of. What is really interesting is we're making progress even in patients with brain metastasis, and we're finally getting some insights into what is different about these tumors. And then finally, I'd like to then just close at the end with talking about what all of this means for how melanoma research is moving forward. So with that being said, let's talk about diet and the microbiome. And so I will go ahead and say that one of the great things about talking about diet and the microbiome is it allows you to use pictures that are more fun than 99% of the pictures that I use in all of my other talks. And you'll see them sort of sprinkled around. And even though Omid's not here, I think what Omid remembers is the first time he saw me put up a slide with Homer Simpson on it. That he remembers absolutely. So diet and the microbiome. So why did we actually start working on this? And so we actually, again, as we were working in melanoma, we were sort of struck by the observation that research that was being performed on obesity, and obesity, again, is bad in many, many ways, particularly driving the development of cardiovascular disease with heart attacks and with stroke. And because it's so important, there's been a lot of research done to try to understand, well, what is it about obesity that causes those things to happen? And what's interesting is as they've studied obesity, they've actually found that a lot of the things that we see in the setting of obesity are factors and pathways that we've been studying in cancer. So in particular, there's a lot of data that in the setting of obesity, we see elevated levels of growth factors floating around in the blood, particularly insulin and IGF-1, that again are all about sort of getting sugar into cells. And what's interesting about those growth factors is we've been working on them in cancer, because when cancer cells see those growth factors, and so a lot of times that's by them making these growth factors, this activates pathways that make tumor cells much more aggressive. And in particular, they activate a pathway called the PI3 kinase AKT pathway, and my lab and other labs had shown that when that pathway is activated, not only does melanoma have a higher risk of metastasizing, including to the brain, but activating that pathway promotes resistance to both targeted therapy and immune therapy. So the question was, well, in the setting of obesity, if those factors are floating around at higher levels, how does that impact the efficacy of the treatments that we're using for patients? And so at that time, I actually met Dr. Jennifer McQuaid, who at the time was a very talented fellow in the hematology oncology program at MD Anderson, and now is one of our assistant professors, having joined the faculty just last fall. And Jennifer started out with a very reasonable hypothesis, but as you can see on the right-hand side of the slide, somewhat horrifying, is that obesity will be associated with worse outcomes in metastatic melanoma patients treated with immune therapy and targeted therapy. And again, a hypothesis built on the fact that we knew that when we see obesity, we see growth factors that should activate pathways that promote resistance, made all the sense in the world to ask this question. One of the take-home messages of this story is why we do research, because as much sense as that made, it turns out it was completely wrong. So Jennifer very thoroughly actually ended up analyzing almost 2,000 metastatic melanoma patients who've been enrolled on clinical trials with targeted therapies and with immune therapies, and in each case looked at multiple independent trials. And the thing that she saw over and over and over again, and actually not only consistently seeing the effect, but the magnitude of the effect was very consistently across trials, is that instead of our obese patients, and we again were measuring obesity by looking at the body mass index or BMI, that consistently in these trials that the patients who were obese were not having the worst outcomes, they were having the best outcomes. The exact opposite of what we expected. And actually it's a bit of a paradox, because we also had data that in patients with early stage melanoma with clinically localized disease, that obese patients had a higher risk of cancer spreading. And this has actually been reported in other diseases, that obesity could be a bad thing in early stages but a good thing in late stages, and it's termed the obesity paradox. It's actually been reported particularly in colorectal cancer. And so that was the first surprise. The second surprise, and this actually hadn't been reported in other diseases, is that when Jennifer looked closely at the data, pun intended, largely the effect was actually happening in men and not in women. So let me just show you again sort of what I'm talking about. So down here at the bottom, this is actually the largest collection of BRAF mutant metastatic melanoma patients treated on clinical trials with one of our FDA-approved combinations, dabrafenib and trametinib. And so these graphs then are showing the rates of overall survival for the patients. And so at the beginning of the trial, 100% of the patients are alive. Unfortunately, these lines drop because patients are dying. So if we look specifically among the men, the blue curve are the obese patients, the green curve is the overweight patients, and the red curve are the normal weight patients. And interestingly, what we could see is that after 2 years after the start of the trial, for the patients who had a normal BMI, this is not underweight, these are not patients who have severe weight loss from cancer, 35% of the patients were alive. For those who were overweight, 46% were alive. And remarkably, for those who were obese, 64% were alive. This was almost a doubling in overall survival. It is a bigger difference than we have ever seen in a randomized clinical trial in patients with metastatic melanoma. Now, what was also interesting is over here to the right, the 3 lines for the female patients were completely overlapping. There was no difference. And the first time that we presented this data, I got some really angry looks from my female colleagues. What, though, if you look at this in more detail, though, is what is interesting is that in this trial, similar to almost all clinical trials we've ever done in melanoma, is that overall women do much better than men. This is one of the things that we've seen looking at sort of prognosis in early stage disease, regional disease, and distant disease, that women have always done better than men, and we don't know why. And what's really interesting if you look at this is although, again, obesity didn't help women, what we really see is that while most men are doing bad, obese men have outcomes like women. And so we, again, are doing lots of work to try to understand what this driving this association. We did joke about the donut trial, but we did talk about in Texas we just wouldn't have a control arm. So, but the real question is can we figure out why this happens? So because if we can figure out why this happens, then hopefully that unlocks the key to saying how do we get everybody up there, to get everybody even higher. And so one of the things that's quite interesting about it is that for many years we've wondered about the roles of hormones in this disease, and this has again provided even more impetus for trying to understand that. I will tell you quite honestly, we don't have an answer to this, but what we now have is somebody who's really focused on working on this. And so again, this is sort of the new era we're moving into, is that Dr. McQuaid is really doing now a systematic approach to try to convert these types of observations into new understanding. And she's actually doing a combined approach. We have at MD Anderson a bionutrition research core that is literally there to make different types of food for us to actually feed patients different diets and see if we can actually have positive effects by doing specific dietary interventions. What's shown over here is what looks quite complicated is this is, as far as I know, the fanciest cage you can put a mouse into. They actually cost several $1,000s each. And what they do is every single day we know exactly what the mouse eats, exactly what the mouse drinks, exactly how much time the mouse is moving around. And so what Jennifer's doing is a parallel program of developing new clinical trials saying what happens with different diets on the immune response and on different sort of outcomes, and asking in parallel in mice, trying to figure out what are the best ones. And one of the things that's so exciting is that we actually had just this month, and I apologize that it's getting cut off, but our first trial has actually been opened at MD Anderson. It's actually open. We're starting with melanoma survivors, people who've been free of melanoma for at least a year, off of all treatments, but simply to ask the feasibility, well, can we change people's diets? And if we change their diets, does that change their immune system? Does that change other things in the body? And then one of the things that we're most interested in, and I'll use this as a transition, is does it change the microbiome? And so let me transition into why we're interested in asking about the microbiome. And this is work where, again, I've been happy to contribute to it, but this is work really driven by Dr. Jennifer Wargo. So Jennifer Wargo is a physician scientist surgeon who's not only one of the best physician scientists we have in our institution, but probably in the whole melanoma field. And Jennifer has spent a long time helping us to understand why patients develop resistance to immunotherapy, why patients develop resistance to targeted therapy, and this has really opened up completely new lines of investigation. And so one of the things that Jennifer became very interested in is the human microbiome, i.e. the bacteria that are present in our bodies. For those of you who don't know this, for every normal cell we have in our body, we estimate we probably have 10 bacteria. They completely outnumber us. And most of them are located either in the intestines or on the skin. And what's really interesting is that there's data growing in many, many, many different diseases that differences in the microbiome can have impact on our health. And that includes in diseases like diabetes and inflammatory bowel disease, eczema, allergies, but what's really neat is new data that this is actually important in cancer. And so Jennifer is the one who really proved this in melanoma. So there was a lab that had done some work in the laboratory showing that changing the microbiome in mice could actually impact how effective immune therapy worked in mouse models. But what Jennifer did is the first time actually showed in patients that the microbiome matters. And so this was an effort where we were already, again, following patients who were being treated with anti-PD-1 immunotherapy. We had been collecting blood, collecting stool, collecting blood, collecting biopsies, but what we did is we launched this project to collect stool samples. And I have to say we were quite timid at the beginning, coming to patients and saying, would you mind sending us a stool sample? And I have to say that actually, I think it's in the end, over 80% of patients said absolutely. So with that, what Jennifer was able to show was that if we compared patients who responded to immunotherapy versus those who don't, when we sequenced all the bacteria that were present, what we actually found is that patients who responded had a greater diversity of bacteria in their microbiome. We couldn't actually nail it down to any single bacteria. There's actually multiple different bacteria that are more common in patients who respond and others that are more common in patients who don't respond. But I think it's overall this diversity thing. And again, looking here at one of those curves of how patients did, if you look here, these are the patients who have what we say high diversity of the microbiome, or just doing markedly better than patients with low diversity of the microbiome. Now, again, when we see this in patients, this is what we call an association. We recognize it could just be a coincidence. We may not be asking the right thing. But what Jennifer's lab did is they actually took stool samples from patients who were responding to PD-1 and stool samples from patients who weren't responding to PD-1, put those into mice, and showed that the mice that got the good stool samples actually rejected tumors more effectively than mice that got the not so good stool samples. So this actually suggested that not only, again, was this potentially an important determinant, but maybe we could actually use this therapeutically to make immunotherapy work better. And so with that in mind, we've now launched one of the first clinical trials to assess in patients with metastatic melanoma, can we make immunotherapy work better by changing the bacteria that are present in the intestines? And this is a trial that's being run through the Parker Institute for Cancer Immunotherapy. This trial is open at MD Anderson, and fortunately, the only other place in the country it's open is here at the Angeles Clinic with Dr. Hamid. So I get to put Omid's picture on the slide as well. So it's an exciting trial. There's actually been data presented recently from a couple other institutions that are doing similar trials that have actually shown that in patients who had progressed on PD-1, that when they got treated with stool transfer, that some of those patients have now responded to PD-1. And actually, again, starting to have our first evidence in patients that maybe this would be an effective strategy. And again, I can tell you something we never, ever, ever guessed we would be trying to do. But again, that's why we do research, to try to find new things. Now, one of the other parts that's been interesting is the intersection between all of these ideas. And so now what we have really is an organized effort that involves many different people, including particularly Dr. Wargo, but also Dr. McQuaid, working together where we've been following patients and actually now not only collecting blood, not only collecting stool, but asking questions, well, what food are you eating? How much exercise are you getting? And so some of the initial results that we've seen, these are very preliminary, these are unpublished, they've been presented before, but we asked if patients were taking probiotics, because we started to see a giant spike in how often patients were taking probiotics when this data started coming out, and we looked again, if we tested their stool and measured the amount of bacteria there, interestingly, that diversity that we're interested in that seems to correlate with better outcomes was actually lower in the patients taking probiotics than in the patients who were just taking a normal diet. And interestingly, we've also seen that if we look at dietary fiber intake, which has been shown in multiple studies to have many good effects, including on microbiome diversity, that responders to PD-1 were much more likely to have a high fiber diet than the non-responders. Now, all of this, again, at this point is associations, and as I mentioned, we have labs. We're trying to functionally really determine what are the best things to take, what are the best things to eat, and this is, again, to me, where it's exciting. We now have this whole new area of research opening up, and again, none of this happens without patients participating in it, but it is also that thing where you need people like Dr. Wargo and Dr. McQuaid taking our observations from the clinic back to the lab, hopefully to define new treatments that we then bring back to the clinic. Now, that's all at one end of the spectrum, and so I'd like to then close talking for a few minutes about the other end of the spectrum in brain metastasis. As I mentioned, this is something that I've been particularly passionate about because in some diseases, it was a problem that when we developed effective treatments, that as patients lived longer, they started to see patients being diagnosed with brain metastasis. Unfortunately, in melanoma, we started having this problem even before we had effective treatments. And so for patients who are diagnosed with stage 4 melanoma, up to 20% of them will have brain metastases at their diagnosis. And we know that historically, the survival of those patients has been much shorter than patients who don't have brain mets. And now that we do have effective therapies, unfortunately, the brain is one of those places where the treatments will fail, and often our treatments fail there before they fail anywhere else. Really, one of the biggest frustrations we've had is that one of the things that a scan like this does is it usually also means that patients can't participate in clinical trials, because historically, companies have said if you have cancer that's spread to the brain, you can't participate in clinical research. So one of the exciting things that I wanted to tell you guys about, I wanted to tell Omid about, was that we actually had a workshop sponsored by the FDA just a month ago, in which they brought together investigators from many different fields, but particularly from melanoma, from patient advocacy groups, and from pharmaceutical companies to review why do we exclude patients from clinical trials. And what we and others have shown is that including patients in clinical trials doesn't harm the clinical trial. Not only can our treatments that work in the body work in the brain, there's actually examples now of some treatments that actually seem to work better or faster in the brain than they do other places. And so really one of the things that came out of the discussion, and we expect there to be formal recommendations, is that informally, what's going to happen is companies are going to have to specifically defend why they would exclude patients from clinical trials, that the default should be to include patients with brain metastasis in clinical trials. And to be quite fair, many people from those companies stood up and said, absolutely. So I think this is, again, going to be one of the transformative things. If we simply actually can change the access to clinical trials for patients with brain metastasis, that will be a huge accomplishment. What was also pointed out, though, is that for as much that we know that brain metastases are a bad thing, they're difficult to treat, there is an unmet need for more research to understand why they're so aggressive. And again, as somebody who takes care of patients, and again, this is what we're always afraid of, this has been the other thing my lab focuses on. We focus on therapeutic resistance, and we focus on brain metastasis. And so my lab has done some focus studies looking at sort of brain metastases that have been resected from metastatic melanoma patients. We've seen some differences by using sort of focused hypotheses and focused approaches. But what we really wanted to do was to look globally to ask what's different about brain metastases than melanoma growing in other places in the body. Now, again, one of the things is this all happens in the setting of us having made significant progress on the clinical side. And so in particular, my colleague Hussein Tabi reported a clinical trial where we treated patients with small asymptomatic brain metastases, and that means they didn't cause headaches, they didn't cause swelling, patients didn't need to be on steroids, and treated them with the Ipi-Nivo combination. One of the important outcomes is that we didn't see any higher rate of side effects or any new side effects because patients had tumors in the brain. What was really exciting is that over 50% of the patients had significant shrinkage of the brain tumors. And Hussein's going to update the results from this trial at ASCO this year. The abstracts have just been released, but at the time this data was published, over 90% of those responses were still ongoing. The one-year overall survival rate, which historically has been 4 months, the one-year survival rate in this trial was 90%. So remarkable results. Again, and really the proof of principle that immune therapy can work even in patients with brain metastases. Now, as impressive as that sounds, we who take care of patients know this actually doesn't apply yet to patients who require steroids, which unfortunately is quite common when melanoma has spread to the brain. And this is a regimen that does have a lot of toxicity, and it was notable that even in the setting of seeing such great responses, it's really about 40% of the patients who progressed quite rapidly through this treatment. We didn't really see sort of anybody in between. So again, market progress. I actually led the first clinical trial of BRAF and MEK inhibitors in BRAF mutant patients with brain metastases. Down here at the bottom, this is a waterfall plot that shows what was the change in tumor size in the brain metastases when we treated with the BRAF and MEK inhibitors. Anything that goes up means the tumors grew. Anything that goes down means the tumor shrunk. And quite remarkably, you can see is that in approximately 80% of the patients, we at least stopped the tumors from growing. And by our clinical trial criteria, 60% developed responses in the brain. And actually, these are for drugs that we used to think wouldn't actually get into the brain. And although that's quite positive, and again, it was safe, we didn't see any new side effects, the problem is that the duration of these responses was about 6 months. That's actually half as long as what we see in patients without brain metastases. And actually in this trial, over 50% of the patients actually progressed in the brain while their other tumors were still shrinking. And again, pointing to this idea that there's something different about brain metastases than tumors in other places. And so we've done a project where this is actually over here is Grant Fisher is a very talented very talented and exhausted MD PhD student. He's actually graduating next week. He went back and actually reviewed our pathology holdings at MD Anderson to find every single resected brain metastasis that we had from patients with metastatic melanoma that had good enough quality tissue for us to do contemporary molecular analyses, and ended up identifying 88 brain metastases from 76 patients. What he then did was went the extra yard to say, okay, for those 76 patients, how many of them had had other tumors resected? So we actually ended up with the largest collection of patients where we had not only their resected brain metastases, but also metastases from other sites, extracranial metastases or ECMs, from 34 of these patients. And the primary thing we focused on was getting RNA out of these tumors because we can do RNA sequencing, which globally looks at all pathways that are present in the tumor cells to ask what's the heterogeneity of brain metastases, what makes them different from tumors growing other places. So let's talk first about what we saw among the brain metastases, because this is the largest group of brain mets that have ever been analyzed this way. And what we saw is you take the RNA sequencing data, you put it through a computer program, and it tells you what are the groups of tumors. And so similar to almost every other study we've ever done in melanoma, what it showed is that the tumors fell into two groups, those with a lot of immune cells in them and those with very few immune cells in them. This is very similar to what we've seen in metastases to other sites. Now, the computer is always going to come up with groups. It doesn't know if those are important, but supporting that this was important when we looked at the survival of those patients after they underwent surgery, the patients who had tumors with high amounts of immune cells lived longer than those patients who didn't have as many immune cells. So that suggests we really want to get immune cells into those tumors. And so we asked, well, why do some of these tumors have more immune cells? Why do some have less? We looked at mutations, we looked at pathways, we looked at all sorts of things. None of those actually correlated with the degree of immune infiltration. There was only one thing that we could find that was different between them, and this was a clinical factor. What we found is that for the patients who had had their tumors radiated previously, they had more immune cells present in their tumors than the patients who had not had radiation. This is really important. We have hoped and hypothesized that radiating tumors may be a way to boost the immune response. And we actually have retrospective studies that have looked at patients who've gotten radiation therapy and immune therapy with brain metastases, and retrospectively, it looks like those patients often do quite well, and this is leading to clinical trials to ask prospectively if radiation will make immune therapy work better in the brain tumors. This is actually, as far as I know, the first objective data from brain metastases to support this. So moving on from the heterogeneity of brain mets, what's different between brain mets and extracranial mets? So the first thing is that although the immune infiltrates in brain mets are heterogeneous, consistently what we see is less immune cells in a patient's brain tumor than in their tumor elsewhere in the body. And this probably explains why with many of our immune therapies, like single-agent anti-PD-1, where having immune cells present is so important to the response that generally doesn't work as well in patients with brain mets as it does in other sites in the body. So it's, again, consistent with data we've seen before. The other major difference that we saw was actually not about oncogenic signaling pathways or BRAF mutations or anything like that. It was that the brain tumors were very different metabolically from the tumors growing at other sites. And in particular, what we saw consistently in almost all of the tumors is that they upregulated a pathway called oxidative phosphorylation. This to us was quite interesting because the other half of my lab that works on therapeutic resistance had previously shown that oxidative phosphorylation is expressed in very high levels in about 30% of melanomas, and when that happens, it makes them resistant to targeted therapy. And a guy named Greg Del Goff at Pittsburgh actually published some data very recently also showing in patients and in mice that melanomas that have high levels of OXPHOS, that they're also resistant to PD-1 immunotherapy. And so again, this metabolic change may not only be an adaptation to the environment, but something that actually changes the therapeutic resistance of these tumors. And so we wanted to ask, although we knew OXPHOS was being used in these tumors, is it actually important to the survival of these tumors? So this is where we went back to the mice, poor little mice. We implanted tumors actually in the brain. We actually implanted cells there that were BRAF mutant, where we knew that they were resistant to BRAF inhibitors, and they're particularly resistant when we implant them in the brain. And then we treated these mice with a new medicine called IX010759 that's been developed at MD Anderson, is currently in phase 1 clinical trials, which is a very potent and selective inhibitor of oxidative phosphorylation. And we started treating these mice with this medicine. What's shown here on the left is that this is a mouse that didn't receive the treatment. The red is essentially a surrogate for how much oxidative phosphorylation is there. We showed that when we treated the mice with our drug, which was squirted into their mouth, sort of like taking a pill, is that we were able to successfully inhibit oxidative phosphorylation in the brain tumors. What was pretty remarkable is the first cell line we tested. This is a BRAF mutant melanoma. It's a very angry cell line. It's resistant to just about everything. We just asked, well, what happens if we just treat it with the OXPHOS inhibitor? No BRAF inhibitor, no immunotherapy. And what happened was we got a marked improvement in the survival of the mice. And actually what we did is we actually stopped the treatment when all the control mice were dead. And just having treated with the OXPHOS inhibitor actually cured 30% of the mice all by itself. And so again, it really supported that not only was OXPHOS at high level in the brain tumors, but it was functionally significant. And we're now building upon this, saying, well, what happens if we combine the OXPHOS inhibitor with other things, or look at other metabolic pathways that these tumors are using? But I wanted to show you one more result that's really quite interesting. So we worked with Sherry Holman as a collaborator at the Huntsman Cancer Institute in Salt Lake City. She developed a mouse model where she can actually introduce melanomas into the skin of these mice. So this is sort of, they develop melanomas, and as you let those mice survive, those melanomas will spontaneously metastasize to the lung and to the brain. We actually showed in her mouse model that just like what we saw in the patients, is that the brain mets had much higher levels of OXPHOS than the lung mets did or the primary tumors did. So we collaborated with her lab. She generated these primary tumors, and then we started treating the mice with the OXPHOS inhibitor. And that's shown here in blue. The red is the control. And when we looked at the primary tumors, treating with the OXPHOS inhibitor was actually pretty disappointing. It had no effect on the primary tumors. The primary tumors grew very quickly, and the mice had to die when those tumors got too big. When the mice had to be sacrificed because those tumors were too big, we then actually took out the brains of the mice and the lungs of mice, and we looked for metastases. And I apologize again, it's cut off. What's shown over here is that when we looked at the lungs from the mice, there was a small effect with the OXPHOS inhibitor on reducing the number of lung mets. But as Mark talked about earlier, this is a difference that is not statistically significant, i.e. it's not big enough to know if it's real or not. What is cut off here is that not a single mouse had a brain met when we treated with the OXPHOS inhibitor. It had either prevented brain mets from forming or had eliminated any micromets that were there. And so it actually, again, we've never seen anything like this, and in particular, it suggests a new paradigm. So we've talked about patients with brain mets being excluded from clinical trials. This data suggests that if we want to figure out if this is a good medicine for patients, it's actually patients with brain mets that we should be treating. And that is potentially a new paradigm for us for clinical trials, something we're, again, very interested in. Again, we're working on trying to figure out not just one approach, but multiple approaches that take advantage of this new information. So just to close in terms of where we sort of stand, again, we started as a field with this real sort of analysis of looking at those pathways that are activated in tumor cells, which led to the development of targeted therapies, studying the immune system, trying to figure out why it couldn't recognize tumors, and that led to the development of immune therapies. And that, again, has brought us a long way. I think what we're moving into, though, is a much more complicated world. We now know that we don't need to just look at your blood. We don't need to just look at your tumors. We actually have to look at the whole person. Things like age seems to matter, sex seems to matter, obesity seems to matter, the microbiome seems to matter, and actually where the tumor cell is growing seems to matter. What's very exciting about the research that we've done is it's already leading to new strategies for us to try to see if we can improve outcomes further. So, as I said, none of this research wouldn't have happened without the generosity of patients not only participating in clinical trials, but also, again, being willing to donate extra samples of blood, letting us do tumor biopsies, letting us analyze stool samples, and also the support of many different philanthropic organizations and governmental agencies. And so with that, I'd either be happy to take questions now or over the coffee break.